Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And on our podcast this year, we are introducing a new series that we're calling Heart to Heart. In this series, we'll be speaking with patients and the healthcare providers who treat them. Our hope is that you'll be encouraged and empowered by their stories, whether you are a survivor, a healthcare provider, or a supportive family member or friend. So thanks for joining us on this episode of Heart to Heart. In this series that we have called Heart to Heart, we explored the intersection of heart health and cancer care through the stories of those who have lived through that experience. And as usual, I'm joined by my co-host, Dr. Susan Dent, who is at the University of Rochester working as a breast medical oncologist. She's also the director, importantly, of the survivorship program there. So welcome, Susan.
Thank you.
Good to have you. And today we have a unique opportunity to speak to someone who is in an unusual position in that she is both a practicing physician and a Hodgkin's lymphoma survivor. It's a real pleasure to welcome today Dr. Samantha Siegel. Welcome, Samantha.
Thanks for having me.
Well, maybe you could just start by giving us a little context for your background, your experience, your history, particularly both as a physician and a cancer survivor. I know you're working with Kaiser Permanente now, but tell us a little bit about your career leading up to your diagnosis and then how things began to change from there for you.
Yeah, absolutely. Well, thanks again for having me today. And I guess I'll start off by saying that when I first began practicing clinical medicine after internal medicine residency, I started off as a hospitalist, which for those listening who don't know, that's an internist who mainly focuses on taking care of patients in the hospital. So once you go through the emergency room and it's determined that you need to be admitted to the hospital, then a hospitalist usually is the person who admits you and takes care of you for the duration of your stay. And after I did that for a few years, I transitioned into outpatient medicine as a primary care physician for Kaiser Permanente. And I always found that trajectory really interesting, even before my own diagnosis, because I found that the way that I approached problems and thought about diagnoses in the outpatient setting, having started off inpatient, was a little bit different than people who had done just outpatient all the way through, particularly people who had come from family medicine training. People who practice primary care medicine are usually either internists or family medicine doctors or OBGYN doctors. And those three trainings are quite different, actually. And I found that because I had done internal medicine training, which was heavily inpatient focused, and then I was a hospitalist for a few years before I went into outpatient medicine, my mindset was always like, when somebody came in with this symptom, let me rule out the worst things first, because I felt that naturally, like I would often see those things present to the hospital, people who came in with, concerns that ultimately were diagnosed with really serious things, or people who had seen outpatient clinicians like a number of urgent care visits or sort of bouncing around to just whoever was available and really struggled to get diagnosed. And I found that oftentimes when people came in, the things that I was concerned about ruling out first were often the deepest, darkest fears on the inside for people as well. Like they wanted to know whether or not they had cancer or a clot in their lungs or something serious like that. So that was really interesting. And I noticed a difference from how some of my other colleagues had practiced. And back then, it was just something that I made note of. And people used to joke, oh, you're a dark cloud, or you're always looking for the worst thing. But I was just so heavily influenced by being an inpatient clinician first and needing to rule out those things. And then practiced primary care for a few years. And then in 2021, kind of just felt like I was minding my own business, busy doctor mom, of 3 kids and working and marathon runner, and at that point was just really struggling to bang out my 10-mile run. Like that was my baseline at the time, and just kind of thought, well, I don't know really what's going on. Maybe this is what it means to get into your late 30s, and then developed a cough. And there were some California wildfires going on at the time. So I thought, well, maybe that's what explains that. And then pretty crushing fatigue, hitting the couch at 8, 9 p.m. But again, I thought, well, I have 3 kids. I'm a doctor mom. It's the middle of the pandemic. I didn't know anybody who wasn't tired, just trying to adjust to the constant, daily disruptions of the healthcare system and trying to figure out COVID and vaccination, and just diagnosing people. So discounted that symptom. But then when I had a rock hard, painless, rapidly growing lump above my left collarbone, that's when I thought, uh-oh, this is something serious. And I pretty much knew right away that it was going to be something cancer. But getting diagnosed was from first symptom to getting diagnosed, I would say there were a few weeks to a month there, which is not bad. um, you know, Considering how many patient stories I've heard, and it took months, even a year for some people. So yeah, I was diagnosed with Hodgkin lymphoma after initially hearing some other conjectures about other diagnoses. I was told even before I got my biopsy results that maybe I had metastatic breast or lung cancer just from the looks of the scan, because my breasts were lighting up on the CT scan because I had just finished nursing my daughter. And so the person who the ear, nose, and throat clinician who I was initially referred to for biopsy of my neck node, without knowing that history, saw something lighting up on the breasts and said, I think you have metastatic breast cancer. And that was devastating. And so then when my pathology came back and it was, quote, just Hodgkin lymphoma, it was this really weird whiplash of like, we thought it was this thing and now it's this thing, and maybe that's more treatable and curable. And immediately went into the litany of very strange comments like, you won the cancer lottery, this is the good one. If you have to have cancer, this is the one to have. And so it was just so odd because I felt my whole world crashing down, but really didn't even feel the space to process the grief of the life that I was soon to leave behind and everything that was ahead of me, and quickly began a really intensive multi-drug treatment, which I'm happy to share with you more about. But yeah, that's how it all began.
So Samantha, thank you, for sharing that with us. And it's just, as you said, this was during the pandemic and we were all stressed. And I can understand how, initially you thought that this was just part of life and managing your life during that time period. I think one thing you pointed out, which is so important, is that what we say to individuals when they're going through the process of being diagnosed, and you have to be so
Yes.
careful
Yes.
to sort of what you say in terms of presuming a diagnosis or not until you actually have that final pathology report. Maybe you can just tell us a little bit about, you were diagnosed with Hodgkin lymphoma. Can you tell us a little bit about what your treatment entailed?
Absolutely. So, Hodgkin lymphoma is treated usually, or at least my situation, my first line regimen was called ABVD, which is a cocktail of 4 pretty toxic, or they're called cytotoxic chemotherapy drugs, kind of your more traditional drugs that have been around for a really long time. And we've been using this regimen for decades and decades to treat patients with Hodgkin lymphoma. And not only was I given those 4 drugs, but in order to tolerate those 4 drugs, I was given a cocktail of other drugs, including steroids for chemotherapy-induced nausea, vomiting. Some of the anti-nausea drugs in the initial cocktail even included a class of drugs called antipsychotics, like olanzapine or Zyprexa, which is pretty commonly given these days for nausea, vomiting. And I would say that the cocktail of the chemotherapies themselves, plus the meds that I was given for the anti-nausea regimen, um, I was surprised that I thought that when you get diagnosed with cancer and you go on chemotherapy that you're supposed to lose weight, but I gained weight pretty quickly, actually. I put on, through that first course of treatment, about 40 pounds. So I wasn't vomiting, but I quickly, lost all my hair, and became, very bloated and just this kind of doughy, puffy skin. And it was really shocking to see that the more weight that I put on, it was almost like the way my gut microbiome was changing, my digestion, everything, like that it became its own sentient being and my cravings changed. Like the more metabolically ill that I became, I started craving worse and worse food. And it was just this spiral. Like every day I felt like 2 or 3 pounds, 2 or 3 pounds, and it just kept going up and up. And I would say in the middle of that, I started developing a cough after a few months on that regimen, after my initial cough had gone away. And that's what had tipped us off to the fact that I was probably developing a complication from one of my drugs called bleomycin that was causing a lung toxicity. So dropped that one a few months into it and was able to just continue on the other three. But boy, by the time I got to the end of 6 months of that treatment, I was quite sick. I mean, I went from I'm having difficulty banging out my 10-mile run in the beginning of things to couch bound and prediabetes and liver inflammation and borderline hypertension. I even developed this pretty sudden appearance of this rash called acanthosis nigricans, which is a rash of insulin resistance when you're having glucose issues. I mean, in my armpits and my groin, this kind of dark velvety rash. At first, I didn't really know what it was, but then it became rather obvious, and it was just so shocking to see how quickly metabolically things shifted for me. And I really didn't receive any counseling on that. I think that was probably for a number of reasons. One is I think that there maybe were some assumptions made, like, oh, she's a doctor, married to another doctor, she probably knows. Um, and that's I really felt that that was a little bit kind of misguided. I received really sort of what I feel is outdated nutritional advice, like, oh, just eat whatever you can get down so you don't lose weight on chemo, like steak and ice cream if it tastes good, just whatever calories you can get in. Don't worry about your diet, things like that. And that was sort of how it all started. And so on steroids and really whatever tasted good, I did eat it on days when I felt good, because there were other days when I couldn't eat. And so when I got to the end of that 6 months and I got that post-treatment PET scan that showed no evidence of disease, it felt like my medical team was popping champagne bottles like, woo, no evidence of disease. You're great. You're in remission. Are you going to go to Hawaii? And at that visit, I'll just never forget. I was sitting there in the room thinking, oh my God, I know you're happy for me, but please read the room. Like, I am a miserable person right now. And I feel like a shadow of my former self. I was struggling to run 10 miles in the beginning of this. Now I get short of breath just walking in my mailbox. I mean, it was such a far fall for me. And not to mention the cognitive issues that I was experiencing at the time, difficulty stringing 5 words together, just sort of life as I knew it was rapidly changed, and it was devastating for me. So even though it seemed like it was a good outcome at the time, it was really quite shocking. And within a month of that visit, despite that clean scan, that post-treatment PET scan, I started developing symptoms that were eerily reminiscent of my initial symptoms and got diagnosed with a relapse in a few months after that. And so then I fit in this new group called relapse refractory Hodgkin lymphoma, and learned that I would soon need months of salvage treatment in order to get me into remission so that I could undergo a stem cell transplant with my own cells, and then ultimately a year of additional treatment after that stem cell transplant. So it was like I had just scaled one mountain and then there was another one.
And Samantha, that, it's remarkable. You already said you're already feeling so beaten up, so to speak. Really did not feel well, had
Yeah.
a short of breath. Your functional status was quite poor. and then to be told you've got to go through a lot more treatment and then a stem cell transplant. Tell me sort of how that, how did the team, what kind of support did you get through that process, whether that be medical support, emotional, or otherwise? Because I think that is a part of the cancer treatment that we often, I think, overlook, and we don't spend enough time focusing on, the other part of treatment, which is supporting you through this, right? Because you were facing a lot of treatment after just coming through what you felt was already very difficult.
Mm-hmm. Absolutely. I guess I had a couple thoughts when you mentioned that. The first one is that thank goodness for clinical trials and cancer care because, the standard of care for the salvage regimen or the treatment regimen that would bridge me to transplant, even a year prior would have been another multi-drug cocktail called ICE or DHAP, like some really intensive multi-drug cytotoxic chemo regimens. But there had just been a clinical trial about this drug called brentuximab vedotin, which is an antibody drug conjugate, kind of like a smart chemo, as they call it, that delivers the therapy just to the cancer cells that express the receptor instead of all the cells to your whole body. And because there had just been this clinical trial that proved that it might be effective to bridge people to transplant, it might be just as effective as these other drugs and had a better safety and toxicity profile. They brought that up to me as, hey, do you want to get the standard of care thing, which is this multi-drug, regimen, or do you want to try this, single drug for a couple months, see what happens, and then if it doesn't work, then we escalate to those other things. And that was an option only because there had just been a clinical trial within the last 6 months or a year that had proven that that might be an option. And the way that I was feeling at the time with all those toxicities, I thought, yes, please. I just jumped right at that. And I was so grateful because I was able to get bridged to transplant pretty much with that drug alone, and then just one dose of cyclophosphamide to mobilize my stem cells. And that was, I was so grateful for that. But you're right. In terms of the supportive care, it was really lacking in my opinion. And I just want to say, open-heartedly, I'm so appreciative for my care, and I feel that I got really good care overall. But I think that all the suffering in my experience just opened my eyes to, even when you have good care and you're starting from, somebody who's well educated and lots of resources, the gaps are tremendous. My primary care doctor, who's a close friend of mine and is amazing, was kind of nowhere to be found. It's not through any fault of his own. I think it's just that's the practice model in the healthcare system where I'm living. I think if I had reached out about certain things, he would have tried to go to bat for me, but there wasn't any process in place for him to be involved. And it was this kind of old school thinking of there are different silos. There's the primary care silo, and then once you get diagnosed with cancer, you go over there to that silo and never the twain shall meet. There's sort of these two separate lands and they're not connected at all. And so even though I know that he would have gone to bat for me if I would have reached out, there was just no process for him to be involved. And as far as oncology went, I think my oncologist was really focused on just getting me diagnosed with the relapse, which took a number of biopsies, actually, because my PET scan looked convincing for a relapse. But, Hodgkin's are classically these really, really big cells. And so the first biopsy that we got was a fine needle biopsy, which just got, necrotic tissue that was around the cancer and wasn't able to actually get to the cancer itself. So then I had to get a bronchoscopy procedure where they put a scope inside your airway and they biopsy through my airway. And that was non-diagnostic. So then I had to go all the way to a thoracic surgery to sample a lymph node under my aorta. And that was ultimately how I got diagnosed and confirmed that I was having a relapse. So I think she was just really focused on getting me through all of that. And she had me assessed by social work in the very beginning, which is kind of how things are done typically. And in the very beginning, when I was assessed, like, what do you need? How are you doing? I was fine. I was a doctor, married to another doctor. We had money. We've got a support system. I felt good. My mental health was good. And when the social worker came over to see how I was doing and what I needed, I pretty much waved him off like, I'm fine. I don't need anything. And I kind of was really not reassessed after that. And, given that I was having trouble stringing 5 words together, I don't even know that I knew how to articulate how much I was suffering, in terms of my kids watching me be so sick and the side effects that I was experiencing. And everybody was so focused on saving my life that the quality of the life that I was living really just seemed like an afterthought or like a future us problem. Like, okay, if you get there, if you survive this, then we'll talk about that. And at the time, I don't know that I even had words for that, but looking back on it in retrospect, I think that's how I felt.
Think, you bring up some really interesting points is that we tend to focus on the very beginning when people are diagnosed. And then in survivorship, we kind of think of survivorship, well, you finished your therapy or your number of years out, and then like what is happening then? But there's that huge piece in between where, your needs can actually be changing over time based on your treatment.
Yeah.
And I think you're right that we have to think about changing the model to not only including the entire team, whether that be your primary care provider, your oncologist, your surgeon, your radiation oncologist throughout your treatment, but constantly reassessing what those needs are. Because as
Yes.
you clearly outlined, those needs change. And what you need at the very beginning of your diagnosis may be very different than what you need after 6 months of punishing cancer therapy. So,
Absolutely. And there's also this, I call it the cancer bystander effect. Like, again, I think that individually, my providers have all been really excellent. It's the process that is just very unkind. And at times, like everybody else kind of thinks somebody else has it. I think that oncology thinks maybe the social work has it when it comes to asking about your kids and how they're dealing. And your primary care doctor thinks that oncology has it. And then oncology sometimes thinks that your primary care doctor has it when it comes to other health conditions. And it really feels like the patients carry the weight of it all and communicating between the silos. And that's just really hard when you're in the thick of it.
so, having said that, can you maybe then tell us what some of the biggest challenges are in managing both your cancer survivorship and some of the cardiovascular or metabolic issues you experience?
Absolutely. Well, I think one is that I didn't hear about the word survivorship until I was already in the pit of despair. And so I think that was just a revelation. Like, I think once I had gone through my whole first line of treatment and really was feeling just like a completely different person. And when people were initially celebrating my remission and I felt so sad and despondent, um, I think that's when I turned to the internet and I was like, what do I do? What is this? Why am I so sad when everybody's so happy for me? And that's when I came across the word survivorship. I said, oh, well, you're in survivorship. This is actually a really common thing that people experience, that once you kind of get through the end of treatment, a lot of people then feel safe to experience the feelings that they just couldn't even feel when they were in the midst of trying to survive. And that a lot of people, paradoxically, when things have been deemed, safe or no evidence of disease or in remission, then that's when things hit the fan emotionally. And that's absolutely what I experienced. And then after reading about it, I was like, oh, this is really common, that a majority of people really experience these fleeting thoughts. Like, and it doesn't mean that they don't also feel grateful and joyful and hopeful about their lives, but at the same time, just then having this delayed processing of, oh my gosh, what just happened? What did I just live through? So just learning about the word survivorship, and then also learning about what survivorship entails. I started noticing these different gaps of, wait, some people are using survivorship interchangeably with the word surveillance, which means like how you are monitored for whether or not your cancer comes back or complications from your treatment. But I don't think that's what it is. And I'm learning about all these different organizations that define survivorship as, sure, surveillance for how we monitor you for your cancer going forward and complications, but also your vitality, your emotional well being, your body image, your sexual health, your cardiovascular health. And I started learning about all these organizations, and that, yes, there is this consensus that survivorship is all these things. So that's when I started really getting this fire beneath me, like, okay, I need to not just get this for myself, but if I survive this and have a chance to go back to medicine, this is what I want to focus on doing. And I think one of the biggest aspects of that I learned about was this idea of cancer rehab. I'll never forget the first time I heard about oncology rehab, and it made perfect sense to me in cardiology care or in stroke care, post-stroke care, neurovascular. People have a stroke or a heart attack or get diagnosed with congestive heart failure, and they're put into a referral for cardiac rehab or neurologic rehab that might include physical therapy, occupational therapy, nutrition, helping you, set new exercise goals, stress management, sleep. And I thought, where is that in oncology care? Like people are put through the ringer. I know I certainly was. And there was no process or plan for this is how you reclaim your health and vitality. This is how you begin healing. Um, and so I found my way to integrative oncology and learned about various things that people were trying to heal from the toxicity of treatment, including different dietary interventions, whole food plant-based diet, different time restricted feeding or supervised fasting regimens, acupuncture, massage, sleep optimization, breath work, things even that seemed just a little bit woo-woo and out there that I might have rolled my eyes at in the beginning and suddenly seemed very appealing and attractive because there is very little to no toxicity in those things. And they might give me a chance at reclaiming my health and well-being.
Well, that's really interesting. But, you, as you mentioned, had access to resources. You're a physician. So, at a very different level than many individuals who are facing a cancer diagnosis. So, looking back on your experience, what advice would you give to other patients who are starting their cancer treatment, in particular around their cardiovascular health?
Well, I think that my diagnosis really felt like it started off in crisis mode, and I think that's true of a lot of patients, actually, um, where it just went straight into cancer. Cancer feels like a death sentence. Let's focus on the not dying part. And if there's one take-home message that I really want people to internalize from listening to this today, it's that not dying is not the same thing as fully living. Not dying is obviously really the most important part. But a lot of cancer care is focused on clinical trials that have this sort of arbitrary set point of 5 years. And if you get to 5 years and you haven't relapsed, then yay, we've been successful. And I think we're just really moving on from that old standard to focusing on planning for your survival. And for me, that includes, for advice for people, even if you don't have access to the ivory tower onco PCP unicorn that I now practice as, and there's a couple, there's this growing community of people in cancer care that are practicing cancer survivorship and onco primary care. You can seek onco primary care through your traditional, primary care clinician just by asking for some really basic things. Like right after you get diagnosed, ask them to check your hemoglobin A1C, which is your glucose, so you know what your baseline is. Ask them to check your lipid profile. What's your cholesterol? What's your blood pressure? How much are you sleeping? What is your stress like? Is there any way to scale back at work if you work a really stressful job, or to ask for accommodations for working through cancer? And you can either ask that of your oncology team or your primary care doctor, and really just kind of go in there with this list of, these are the things that I like to assess now. And I'm hoping that we can periodically reassess these things throughout treatment, because I think that might not be readily apparent to a lot of primary care clinicians who don't get training in onco primary care or cancer survivorship, that the cadence of follow-up for testing on certain parameters is different than in the general non-cancer focused population. And what I mean by that is that when you go to your primary care doctor, as long as you don't have prediabetes or diabetes and your cholesterol is relatively okay, you might get that testing done once a year if you're lucky. And that would be considered really good and standard of care. But when you are headed into a treatment that has high metabolic toxicity, like you're going to have steroids, you're going to have chemotherapy or immunotherapy or targeted therapy that is known to increase the risk of glucose issues or blood pressure issues or cardiovascular health. The cadence of follow-up, meaning the frequency of how often you should check those things, your blood pressure, your glucose, your lipids, maybe even an echocardiogram, maybe even a treadmill stress test. That might be like an every 3 or 6 month thing that needs to be done. And that might not be really obvious to primary care clinicians in the community who are practicing outside of big cancer centers or academic centers, but you can learn those things and go in and request those things, and it's very reasonable.
Those are really good points. And I think, based on my years of experience as an oncologist, too often I will see patients who come to us and then they never go back to see their primary care provider again. That we assume, or at least it's thought that we assume not only their oncology care, but much of their care, including, management of their diabetes if they have that, or their lipid profile, or like you said, their A1C. And so I think it comes back again to thinking about that multidisciplinary approach, including the primary care provider is an important part of your care, as are the other healthcare team members, and breaking down some of those silos and working together. I call it sort of the rather moving away from that disease-centric model to a person-centric model, that we're treating an individual, not the disease itself.
I
And
love
that's
that.
so important, particularly as you say, newer cancer therapies are coming into the clinic in oncology. The number of new cancer therapies approved yearly is just astonishing, which is great for curing cancer, but they all come with unique toxicities that we have to learn how to manage in sort of a multidisciplinary fashion. And, you had mentioned earlier about, your training and seeing patients with cancer and they have comorbidities. And the question was, well, do we care about those comorbidities? Do we care if they're hypertensive or if they have dyslipidemia? And I think we kind of brushed that off in the oncology community. And I think we have to be much more aware that, yes, these things do matter, right? That, you still should be thinking about management of your sugars, management of your dyslipidemia. All of that contributes to your total health. And
Absolutely.
so, I agree that oncoprimary care is sort of a movement. It's growing. It is
Yeah,
definitely growing. I mean, I was previously at Duke and we have a oncoprimary care program there. But I think what's important, is education of
hmm,
healthcare providers, as you
yes,
alluded to looking at this different model of care, that we have to move away from the traditional survivorship model of you get a survivorship plan, and that's looking at basically at picking up surveillance techniques, right? Looking at picking up early diagnosis, to survivorship, meaning total
yeah,
care of that individual. I also wanted to mention that, of course, ICOS, in collaboration with the European Society of Cardiology, did publish Cardio-Oncology guidelines in 2022, and they published in the European Heart Journal. And while it's a very extensive document, there are little bits and pieces in there that are very, very relevant for oncologists and even primary care providers can look at. But
absolutely.
importantly, in those guidelines, they have a patient component where there's a booklet that's been written for patients, common asked questions, really trying to promote advocacy on the patient part of the patient. Because even if your provider isn't aware, if you are aware and you bring that to your primary care provider or to your cancer team, that's important too. So, any last words, Samantha, that I'll give you a chance to sort of share with our audience today. This has been a wonderful conversation, but any last words?
Absolutely. I can't believe our time's already up. I could go on about this for hours. But no, I've been heavily influenced by Kevin Effinger at Duke in onco primary care. And he was kind enough to have a phone call with me and to, because I said, we have to scale this. This is so much bigger than you and I. And he said, I agree. And until we can hire a whole army of onco PCPs, like I just focus on teaching existing primary care doctors how to do onco primary care, showing them the tools that we have available. And I have residents and fellows that rotate through my clinic now, and I frequently show them the ICOS guidelines and other long-term guidelines, and just knowing what are your tools, that because it's impossible to know everything. This is a really, really humbling population to work with, and I just think that it's really important if you're a patient, if you're a loved one caring for a patient, to be your own fiercest self-advocate. And that's not from like kind of an antagonistic place, but just that primary care doctors have so many demands, oncologists have so many demands on them, that you are the most invested in you. You are the CEO of your own body. And it's really important to just ask, well, I'm 6 months out from the end of active treatment. Is it expected that I should be having this level of fatigue this far out? Because I have seen certain symptoms after the end of active treatment that are really hard to diagnose. Like fatigue is a very vague symptom, or feeling short of breath. And a lot of people would very reasonably and naturally conclude, like, of course you're deconditioned. You've been sitting on the couch for 6 months, or of course you have fatigue. You just went through 6 months of chemo. But maybe that's not all that it is. Maybe once you're 3, 6 months out, a year out, you should ask, what blood test can I have? Should I have an echocardiogram? Think about what are the mechanisms of the treatment that I took? How did they work in the body? And what does that put me at risk for? And that's what you can ask your oncologist or your radiation oncologist. If you had radiation in the field of your chest or other parts of your body near your cardiovascular system, what treatment did I have, and what does that put me at risk for, that I can educate my primary care team about how they can help me monitor my body and my health going forward? Do you have any suggestions about blood work or other testing that I should have so that I can be as healthy as possible? And for all the metavivors, people who are diagnosed, with stage 4 disease, you are in the survivorship model now. So survivorship starts from the time of diagnosis through the balance of life. Metavivors are living longer. Everybody has a place in this model, and just be your own fiercest self-advocate.
Well, that's just wonderful. Thank you so much for sharing your experience with us. I think this is going to be extremely helpful for our audience. And I'm glad to hear that, you're doing well and really contributing to this whole field now, and really helping us to try and get the message out to everyone about how important it is to work together as a team. I mean, I agree with you. We don't want to just cure the cancer. We want people to, what I say, thrive, not just survive, is sort of my motto. So thank you very much for joining us today.
Thank you for having me.
Thank you for joining us on this episode of Heart to Heart. And if you would like more information about any of the ICOS resources or opportunities, go to ic-os.org. That's ic-os.org for more information.
Free audio post-production by alphonic.com.